This is the Senate Standing Committee on Health and Welfare. This is meeting number 4. The date is Wednesday, February the 2nd, 2022. Madam Secretary, please call the roll.
Senator Rocky Adams. Senator Berg. Senator Carroll. Here. Senator Givens. Senator Harper Angel. Senator Howell.
Here.
Senator Kerr. Senator Meredith. Here. Senator Nemes.
Present.
Senator Wise.
Present.
Chairman Alvarado.
Here. Very good. We have a quorum. We're established to do business. We have 4 bills on the agenda. Let's start first with Senate Bill 87. We're going to go ahead and pass over that bill here today. We'll probably be hopefully addressing that at some point in the future. We were waiting on some information on the fiscal note, which we just got yesterday, so we're going to pass over that bill. The next item on the agenda is Senate Bill 97, an act relating to child fatalities and near fatalities. The sponsor is Senator Danny Carroll. Senator, if you'd like to come to the table, and if you have any guests, if they could introduce themselves and begin your testimony whenever you're ready.
Thank you, Mr. Chairman. I'm Danny Carroll, the state senator from the 2nd District.
And I'm Steve Shannon. I'm a member of the Child Fatality and Near Fatality External Review Panel, and I'm also the executive director of CARP, the Association of Community Mental Health Centers.
Mr. Chairman, members of the committee, it's an honor to be here today to present this bill. This bill originated back during the interim. This was on October the 14th when the Program Oversight and Investigation Committee did the annual review of the External Child Fatality and Near Fatality Review Panel. And during that presentation that day, we began to recognize that, and I think it was 2013 when this panel was established, that there were some shortcomings in the legislation that created that panel. And as a result of that, the state has created a blue ribbon panel to investigate these fatalities and near fatality instances throughout our Commonwealth. However, what we failed to do at that time was to ensure that we were making the most out of their work, to make sure that there was accountability built into the recommendations that the panel made upon review of these cases. Made a commitment that day to work with the panel to create a piece of legislation to address some of these issues, and that's why we're here today. And I think at this point, I will yield to Mr. Shannon and let him give you just a little background on the panel's work.
Again, the Child Fatality and Near Fatality External Review Panel, we review cases involving children who have died, DCBS, maybe public health referrals, or have been injured. And we looked at, in our last year of full data, we looked at 200 cases. 80 of those involved fatalities, 120 near fatalities. It's 20 individuals who come together, wide range, state police represented, lawyers, judges. I represent the mental health centers. We have other behavioral health professionals who participate. We have other volunteers who participate. And we come together, and really, I do a lot of meetings. You know, my children, when they were younger, said I'd lead the league in meetings. This is the worst activity I am involved with. My wife knows when I've had a child fatality, near fatality meeting that day. It's really hard work. The staff is they go through cases of awful things of what takes place, and we review them. And the motivation is to identify trends, data. What can we use moving forward to maybe address some problems? We're hoping that someday this becomes a preventative strategy, and we make things better for kids, make things safer for kids. What I've learned is safe sleep is a real problem. I didn't know anything about it. I have 2 young daughters. When they were babies, no one told us about sleeping with your baby. I'm going to confess this to everyone today. Our oldest daughter, when she was an infant, would get up in the middle of the night coughing. I had learned to hold her in the recliner, and I could put on The Wizard of Oz, and she'd be quiet. And when she got fidgety, I could, in my sleep, rewind it and put her back to sleep. That is unsafe sleep. We didn't know that. This is what the panel talks about, and we talk about those things a lot. We talk about families that are really tough places, and bad things that happen to kids for a lot of different areas. I think it's important work. I think it's invaluable work, and it's just sharing that information, and we pass it on to DCBS. We want to partner with DCBS. They have a really hard job. We don't want to be argumentative with DCBS, but we share that information, and that's what we do. And we meet once a month, so Tuesday afternoon for 4 hours, we go over these cases and talk about awful things that happen to kids in Kentucky that hopefully we can stop talking about those at some point is really the objective.
Mr. Chairman, we have a committee sub. If we could go ahead and get that adopted.
Certainly. We have before us PSS 2 for consideration. I'll entertain a motion. We have a motion. Is there a second? We have a second. All those in favor, please signify by saying aye.
Aye.
Anyone opposed? All right, the sub is before us, Senator.
Thank you. And Mr. Chairman, members of the committee, there are just a few components of this bill that we looked at. We looked to initially build some basic structure into the committee for the accountability purpose, and then there are actually some items on here that are recommendations that the committee has made and some changes that we're making to statute. The first one that I want to go over is a requirement that law enforcement to request blood, breath, or urine when the officer has reasonable grounds to believe that a person exercising control or supervision of the child was under the influence of alcohol or drugs at the time of the fatality or near fatality. And if the person declines to give that sample, the officer is required to seek a search warrant. Once that the officer, it has been established that there is probable cause that one, the fatality or near fatality has occurred, and two, that the person exercising custodial control or supervision was under the influence. And that would be the requirements to be able to obtain the warrant. And these, the blood, breath, or urine will be collected pursuant to the DUI statute 189A.103. The bill also requires that the president of the Kentucky Coroners Association, and a practicing medication-assisted treatment provider be selected by the AG from a list of 3 provided from the Kentucky Board of Medical Licensure, and these 2 positions be added to the panel. This is 2 areas of expertise that the panel members indicated, that the chair indicated would be of value to the panel in the reports that they review. We also added an item related to the publication of the annual report. The panel requested we change that date to February 1st of each year. In one of the main components of the bill, it requires the panel to determine which state agency is responsible for the recommendations related to a panel review. And once they have determined which agency would be responsible to address this recommendation, they would formally send that to this agency. The agency has 90 days to respond in writing, specifying their intent to implement the recommendation in an approximate time frame, or reply with the notice that the agency does not intend to implement the recommendation and an explanation of why they can't. So many times there have been recommendations made and basically they just go nowhere. There is no accountability or follow-up. Sometimes it has been done on these recommendations. So this puts some credibility and some accountability into the recommendations that the panel makes. The bill also gives protections from discovery, subpoena, or introduction in evidence in any civil or criminal actions in any manner that would directly or indirectly identify specific persons or cases reviewed by the panel. And we recognized that as a problem early on. These meetings are open to the public. And so basically an attorney could come or could zoom in or on these meetings and hear what's going on in these reviews. And I know that from a legal standpoint, an officer of the court would have ethics issues if they tried to use any of that, and that's any of that information, that's separate. But we felt like it was a good idea to put this into statute to give protections so that those incidents can be reviewed and conversations can be freely had without fear of any of that information being used for discovery. In the committee sub, we made some changes to the legislative member members that sit on this panel. And it requires now that the Senate President and the Speaker of the House assign one representative from each chamber to serve as an ex officio member. Senator Meredith has a bill that would do away with the child child welfare oversight, and there's some combination of committees that will be made. Felt like this was probably the best avenue to get the ex officio members from the legislature on the panel. On the part of the bill where it talks about someone having control over a child for the purposes of determining blood, alcohol, or getting a blood test, urine, or breath, we simply added the word parent to the term of anyone having control or oversight over the child. This was at the request of one of the board members. And the addition that we made yesterday was a recommendation that the panel had that I think is a very important recommendation, something that really needed to be codified, and that's why we made the change. And under this recommendation in the bill, it would now require a coroner, upon notification of a death of a child under 18 years of age, to report the death to law enforcement, DCBS, and the health department immediately. And this as opposed to as soon as practicable, as is currently in the statute KRS 72.410. And the purpose of that contact is to determine the existence of relevant information concerning the case. So from what I've been told throughout the state, through some coalition meetings, that they've discovered that sometimes there are coroners waiting 2 or 3 days to make notifications to law enforcement or DCBS or the health department on the death of a child. And as a former investigator, that's unacceptable. The possibility of any type of investigation 2 days later would be almost impossible. These cases are some of the most difficult cases that an investigator would work, and the availability of evidence is crucial to the success in any prosecution. And if it's 2 days later, if a child's body's been removed without a detective working the scene, obtaining the evidence, it could have a major impact on any prosecution. One other thing that I want to mention, Mr. Chairman and members, when this committee was established, there was an MOU between this panel and the Justice Cabinet related to funding. And there was supposed to be a $420,000 appropriation that goes to this panel for the function, for personnel, and the other functions of the panel. Looking at the funding that they have had each year, this was never put in line item, and it has fallen short each year. So we will be looking at language in the budget, a line item that will fund this critical panel to allow them to be able to function at their highest level. I can't think of any other panel that we establish in this Commonwealth that's any more important than this. And as an investigator, having these levels of expertise reviewing cases, it can be invaluable in the way we conduct training for our law enforcement, our investigators, DCBS folks, anyone who deals with these types of deaths where there may be some suspicious incident surrounding the death. It could be critical to the success of any investigation, and it would allow detectives, would allow DCBS folks to be more effective in their role when you have this level of expertise reviewing their work. So it is a positive thing. That's the approach that the panel takes, where they work in conjunction with these folks to make a positive relationship. So the benefits to all parties is at a high level. It's not an adversarial relationship. Mr. Chairman, that's all I have.
Very good. Thank you, Senator. Appreciate the work on this. I'm a member of that panel, and I tell you, I think the way you got it restructured for legislative input, I think, is better. It's difficult for us to make. Often they'll happen during proceedings while we're here, and it's very, very difficult to make those meetings. I think this will provide a lot more legislative input the way things are structured as well. We've got a couple of questions. First one is from Senator Howell.
Senator Carroll, thank you for bringing this. And Section 5E1 about the subpoena power if there was a refusal. Is this kind of the dovetail language with what we are doing with DUI law now in response to that Supreme Court case? So that applies with everything
It is exactly the same as far as the process that they would follow to get those samples.
Okay, perfect. Thank you.
Thank you, Senator Meredith.
Thank you, Mr. Chair. Thank you, Senator Carroll, for your bill. You know, from our history together, I like any bill that builds accountability into the system, and I really like the provision that once a recommendation is made, signed to a cabinet, there's got to be follow-up because, again, that's where things fall through the crack. So good bill. Only question I have, and simple question, is on page 13 that talks about the publish of the annual report. What's the motivation for moving it from December to February? What are we trying to accomplish there?
It's difficult to get our work done, formalized, and the cases reviewed. So that gives us just more time to accomplish that. And because, you know, this past year, it was submitted to February 1. We typically ask for an extension anyway, and we've done that last several years. So really, this change is consistent with the practice.
Certainly don't have any problem with it. I was just looking in terms of if upon reviewing the report, we need to look at some possible legislation. That's right in the middle of the legislative session. But I'm assuming that we'll take the report, look at it, and during the interim, we'll work on things that we need. So it makes sense. But
I would think like the report that just got submitted next session would make more sense for some of those recommendations.
And I think this piece of legislation is going to create an avenue, a direct avenue with the legislature to uphold our part of the recommendations, where whoever is sitting on the panel will have access to the information, and then, you know, they can start looking towards legislation, whether it be that or in the Oversight Investigations Committee.
I appreciate that, because I think I've seen a shift over the last 3-4 interim sessions that we're focusing more on preparing legislation for the upcoming session, and it's not just dog and pony shows that we've seen in the past. And I think that's why the interim session should be used, is to develop legislation to be heard later. So I appreciate that. Thank you for your answer. Thank you, Mr. Chair.
Thank you. All right, any other questions from members of the committee? We have a motion on the bill, and we have a second. Any other discussion? Madam Secretary, please call the roll.
Senator Rocky Adams. Senator Byrd. Senator Carroll.
Aye.
Senator Givens. Senator Harper Angel. Senator Howell.
Aye.
Senator Kerr. Senator Meredith. Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye. Matter passes with a vote of 11-0. Congratulations, Senator. This will be reported favorably to the Senate floor. Next on the agenda, we have Senate Bill 105, an act relating to newborn and infant screenings. The sponsor is Senator Max Wise. This has been a topic that was filed last year. We've had an interim discussion on this issue. And Senator, if you'd like to introduce yourself and any guests that you have, and please begin your testimony.
Chairman Alvarado, thank you. Members, thank you so much. And Chairman, I want to personally thank you just for your words. This is a bill, as we filed last session, you were very amenable to working with us. You made the promise that this topic would be brought up during the interim. Just like Senator Meredith said, the use of the interim. Our first meeting dealt with the topic that we're going to be dealing with today in the bill that's before you in Senate Bill 105. Mr. Chairman, there is a committee sub, and if I could ask you to move for adoption on that.
Certainly. We have a motion on the sub. Is there a second? Give a second. All those in favor, please signify by saying aye. Aye. Anyone opposed? All right, the sub is before us.
Thank you, members.
Yeah, I want to make sure that everybody has PSS 2. That's the sub that we've adopted here.
Mr. Chairman, members, this topic is an issue that many of you, if you were in the interim, you knew the story about the Strevall family, and specifically about Belladonna Strevall, and a constituent of mine, the family in Adair County. I was unaware of cytomegalovirus, as most commonly known as CMV, before even coming into the legislature. I hate to say that there's many issues and topics that we're just not experts on or knowing about, but reading an article in the local Adair County newspaper brought it to my attention, and that's where we are today. The constituent story that then became a journey and presents before us today in Senate Bill 105. I would like for my guests, if they would introduce themselves for the record. We may proceed.
Hi, I'm Sarah Strebel. I am Bella's mom. I'm here representing her and her family and all of the CMB families in Kentucky. And thank you so much for hearing us today.
Hello, my name is Sarah Roof, and I'm representing Kentucky Hands and Voices, which is a statewide organization that supports families of children who are deaf or hard of hearing. I do have a 9-year-old son who is deaf, not related to CMV, but in my role with that, I have had the honor and privilege to meet so many families across Kentucky who are impacted by CMV, and that, of course, includes Sarah and her family. We also have Cameron, who is here with us. He has been impacted by CMV with his family. He's here also, and they're from Richmond. But just want to say, I want to highlight, we do have a whole committee that we meet with regularly on this bill. That includes not only parents, but also physicians, audiologists. We also have partners in advocacy with Kentucky Commission on the Deaf and Hard of Hearing, the Hearing and Speech Center in Lexington, among many others, as well as the National CMV Foundation, and you'll hear from some of those. But I want to highlight as well, right before us, they testified, about the safe sleep and different things like that. I know when I was pregnant, I was told, don't change the cat litter box and don't eat deli meat. And the same thing with safe sleep. One big thing we're pushing, which is in the committee sub, is education. And we need to see more of that for our expectant mothers so that they're aware of CMV, because ultimately our goal is to see less cases and then, of course, be able to screen the ones where that is an issue. And then we do have 3 people joining us by Zoom today. Of course, with their busy schedules, they weren't able to be here in person, but I'll turn that over to Dr. Stadler to go ahead and introduce herself as well, and then Dr. Stewart and Amanda.
Hi, good morning. I appreciate the opportunity to talk to you this morning. My name is Dr. Laura Stadler. I'm from Lexington, Kentucky. I'm a pediatric infectious disease doctor, and I have worked towards getting universal screening in our NICU and a failed hearing initiative in our nursery and another local hospital. I also treat infants with congenital CMV with an antiviral to decrease the progression of hearing loss. And I'm happy to talk more later. I'll let everyone else introduce.
Good morning. This is Dr. Dan Stewart. I'm a professor of pediatrics and international pediatrics at Norton Children's Hospital and the University of Louisville School of Medicine. I'm a previous president of the Kentucky chapter of the AAP, the American Academy of Pediatrics, and I was the state champion for the EDDI program from its inception to approximately 5 years ago. EDDI stands for Early Hearing Detection and Intervention. And I just want to state that my statements today represent my own opinion and not those of Norton Healthcare or the University of Louisville. Thank you.
Hi, my name is Amanda Devereaux, and I am the program director at the National CMV Foundation. We're here just to provide our support for the bill. I'm also the parent of a child who was born with congenital CMV, not in Kentucky, but important to note that she was born looking completely typical, even though she is significantly disabled by the virus. So we're happy to provide support and can provide input. There's a lot of activity happening across the country, different types of legislation getting passed. So we're happy to provide information on that.
Thank you, Mr. Chairman. I want to thank all the stakeholders that are on the Zoom, as well as those that work behind the scenes to get in the legislation to us today. So the legislation real briefly provides 2 parts. One's an educational tool piece of where the Department for Public Health would make available on their website, providing educational resources as regards to the incidences of CMV, and that information could talk about the transmission and how that can be before and during pregnancy, as well as birth defects that were caused by CMV, the methods of diagnosis of CMV, and any other preventative measures that can be made available. It also gets into the screening portion of the bill. If you'll look in terms of the legislation that's before you, that every infant in this state who is given an auditory screening test, as is described in KSR 216.2970, and if they fail those initial 2 screenings or have either risk factors associated with CMV, that they shall be tested for CMV no later than 21 days after the date of birth by the health facility or the physician that's providing the services to the infant, unless the parents or guardians of the infant are out of testing. So two components there. I appreciate the compromise. I appreciate the work that was done on this. And I'll open up if Ms. Roof or Ms. Strebo want to provide any other comments or any questions that members may have.
Thank you, Senator. I appreciate that. I appreciate you working with me on this. This is something I know we talked about. I think when the original bill was filed, it was kind of a desire to do a lot of the testing with genetic testing, which is an acquired disorder, obviously. And I know we took a look at what other states have done in this regard and try to find the best options for that. We've got some feedback from a lot of the stakeholders. I appreciate Dr. Stadler and Dr. Stewart being on the line as well. I've reached out to the American College of OBGYN on this issue. They like the language in this statute that's proposed. And perhaps, Dr. Stadler, you're the pediatric infectious disease doctor. If you could comment really quickly. I know I've reached out to some pediatric physicians who feel that there's still a little bit of an unknown on getting a standardized treatment for kids that test positive. There's worries about false positives and children perhaps being, having to be treated for 5 to 6 weeks with ganciclovir or other antiviral therapies. If you could comment as to how much of this you see, how many false positives you see in this regard, and do you think that we're seeing more in the healthcare field of doctors kind of evolving with a proper standard of care when it comes to positive tests?
Yes, so I do not see many false positives. The test screening have high probability of likelihood of a true diagnosis. So the PCRs, which many people use nationally across the country, approximate 98, 99% accuracy. Old school, we used to use urine culture. I've been out of medical school for 21 years, and that was the gold standard. So the current standard of care from the American Academy of Pediatrics Section of Infectious Disease is to identify babies in the first 3 weeks of life such that we can start an antiviral. A publication by Dr. David Kimberlin, who's currently at UAB in Birmingham, was published in 2003 with IV ganciclovir. Many of us were using oral valganciclovir, which is kinder and gentler. It's twice a day. Babies can go home with their family. The publication for that is 2015 New England Journal of Medicine, but many of us were using it in 2013 because we knew preliminary data. And so the current standard of care is to start an antiviral. If the baby's unable to take oral medication, they start with IV, perhaps in an ICU setting, and they transition to outpatient management with an oral antiviral. That publication indicated not just 6 weeks, but actually these babies are on 6 months of oral antiviral therapy. It's twice a day. The babies have laboratory monitoring while they're on that therapy. The medication's kind of claim to fame is to decrease progression of hearing loss. So we know CMV is the most common congenital viral infection in babies. It's the most common preventable cause of infant disability. And so identifying these babies, there's a lot of good reasons to do that, to help the baby and parent family get in for early intervention services so their speech and language development can be maximized. To get them in with audiology, every 3 months they'll have a Bayer or audiology screening to maximize if they do have loss, either hearing aids or eventually cochlear implant. And I think it's real important to identify these babies early, such that families are aware of the diagnosis, and we can start to move forward with maximizing their neurodevelopment. So a lot of what I do is obviously the screening programs, but then our practice starts antiviral therapy if they're candidates, and also just maximize the care and support for that patient and family. It's a multidisciplinary effort. And so audiology, ENT, the general primary care pediatrician is instrumental in that. And there are some other states who provided data, Utah being one of them, that by identifying these babies early, that it reduces the newborns who are lost to follow-up. And so identifying them, giving them a diagnosis such that parents can learn more about their baby. We see better outcomes for the baby and for family. And we're really interested and appreciative of the education component. The other thing I would say from personal experience is often when I meet a family, one of the first ththings I hear is that the mother has largely unaware of CMV, has never heard of this diagnosis. She wishes she could have been educated. Many people want to learn about prevention techniques. And so we're very appreciative of both the OB and pediatric doctors being educated. We think with this bill, it will increase awareness, both in pediatricians and OBs who are monitoring pregnant women.
Thank you, doctor. Appreciate that. Do you recommend, for the screening, if a child tests positive, just for my own education, a PCR test initially or a urine test? I know there's saliva, urine. I've seen all those. So I'm just curious what the initial screening for, if I'm in a nursery taking care of a baby, they fail their algo screening, do I get a urine or do I go ahead and go get a PCR right out of the gate?
So there's 3 acceptable modalities according to American Academy of Pediatrics. Urine, which most characteristically is PCR, but some places are still doing culture, which is very labor intensive. Saliva, and then some people will do serum. There's a JAMA publication early on that the dried LA spot or the blood test or blood PCR will only pick up those babies who are severely symptomatic or have high viral loads. And so at our institution, we chose to use urine largely because of cost. So when I set up the screening program here in Lexington, we looked at cost of urine culture, urine PCR, and saliva. And we also looked at turnaround time, anticipated turnaround time. So the cost to the patient is actually lowest with the urine PCR. The cost to the institution is lower with a culture. So just these little nuances that we have. And then for us at our institution, the saliva PCR, there are some things that make it a little cumbersome. So in the NICU patient population, it's recommended that no baby have what's called an NG, so a tube from the nasogastric location, or babies who reflux, or babies who have recently had either donor breast milk or mom's breast milk. If there's any milk contained in the mouth within an hour, it's possible if mom has CMV in her breast milk that she's either reactivated or has present. That saliva specimen may be a false positive, but other diagnostics that are submitted are not thought to be. So at our institution, we tried the saliva, and in our particular institution, the laboratory with which our organization has contracted with, we had a turnaround time of 14 days. And we found that to be largely unacceptable because we're trying to make a diagnosis within the first 3 weeks of life. So there are several accepted laboratory diagnostics according to national authorities, but at our institution, we use a urine CMV PCR.
Very good. Thank you. We have one more question, Dr. Berg.
Thank you. And this is going to be sort of a trivial question, but I'm noticing that we're including CMV in the list of inheritable disorders. Do we not keep a separate list of congenital in utero infectious disorders in this state? I mean, I don't understand why we're putting CMV in the same category as these genetic in utero problems.
Senator Berg, I'm going to refer to the chairman on that question.
I think if you're looking at the original bill, we've adopted a substitute that's replacing that. Yeah, so it clarifies that. Thank you. We have one more question. Senator Kerr.
Because this is also educational, and because maybe not everybody tuning in today heard this in the interim, could I hear from the mom or from one of the docs to tell how this is contracted, and do we know how it's contracted? Just a little bit of the background on CMV. Maybe would you prefer one of the docs to talk about it?
And maybe they defer to them.
Sure, I can start. CMV is described to me, it's much like strep throat or any other infectious disease. However, CMV is one of the viruses that actually can transfer through placenta walls. So in my case, this is not the same for everyone, but in my case, I was not sick. However, I had to have contacted that sometime during my pregnancy, and my infant contacted that. We had a perfectly normal pregnancy, no complications at all, was born in a local hometown hospital But she did have to be life flighted out because she was very sick at birth. So we had no prior warning to this and no prior knowledge of CMV. It took 3 days before she was actually diagnosed in the NICU with congenital CMV. And at that time, they did try to look back at my history to see if they could identify when she became sick, but I had no sickness, so there was no identification there.
So her being very ill at birth, was that all related to the CMV?
Oh, absolutely, yes. She had enlarged liver, enlarged spleen. Her blood platelets had bottomed out. She was down to like 20 on her blood platelets. She was covered in petechiae, which they also call the blueberry rash. She was very sick, yes. So, and all of that was related to CMV.
Thank you.
So, and it's usually, and some of the preventive measures that we advocate for are especially with young mothers who have toddlers at home, working in daycare settings. So don't put a pacifier in your mouth, sharing saliva, things like that. So those are just some preventive measures that can be used that, you know, when you have a little one, you don't kiss on the mouth, you know, with a toddler, which is not always easy. But those are some of the things. Dr. Stadler, Amanda, I don't know if you all or Dr. Stewart want to chime in with any more.
So go ahead.
Sorry. Yes. So the mother can get a primary infection where it's an illness almost like a flu-like illness. So, but some of the obstetrical healthcare providers aren't even aware of this and may not test for CMV. But more commonly, as Sarah was talking about, the mother may acquire it with changing diapers in a daycare, that type of thing, and not using good soap and water, good hand hygiene, and often it's transmitted like that. But again, to emphasize what was said is that you don't kiss a baby in the mouth, you don't share pacifiers, you don't put the pacifier in your mouth and then give it to the baby to acquire it. But during pregnancy, obviously, a viral illness could obviously be CMV, but it, as is talked about there, we don't always see that.
Thank you very much. I think we have a motion on the bill. Senator Adams has made a motion. Is there a second? We have a second. Any other discussion or questions? If not, Madam Secretary, please call the roll.
Senator Rocky Adams, Senator Berg.
And I would like to say that I really, really appreciate the work that's been done on this bill since the last time I heard it. I think it is strong at this point, and I appreciate that. Thank you.
Senator Carroll.
Aye.
Senator Givens. Senator Harper Angel. Senator Howell.
Aye.
Senator Kerr. Aye. Senator Meredith. Aye. Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye. The matter passes with a vote of 11-0. Thank you all so much for your advocacy. This is the kind of work that pays off. I know sometimes it feels slow, but there is a process to this. Senator Wise, thank you for your work on this as well. It'll be reported favorably to the Senate floor. Thank you all.
And I just want to say thank you one last time. This Saturday would have been Bella's 5th birthday, so thank you. I can think of no greater gift for her and her family. Thank you.
Thank you, sir. Appreciate it. All right, the last item on the agenda we have is Senate Joint Resolution 72. This is a joint resolution directing the Cabinet for Health and Family Services to apply for a Medicaid waiver for individuals with severe mental illness and declaring an emergency. I'm the sponsor. I'm going to stay right here. I think Mr. Steve Shannon's coming to the table also to be able to answer any questions. It was on Dr. Schuster. Very good. Good to see you. She's
good morning. Thank you.
Good morning. I'll be very brief in my remarks. We had a lot of good work done this interim on the Severe Mental Illness Task Force that was chaired by Senator Kerr and by Representative Bentley. We heard a lot of testimony and there are a lot of findings. And for those of you who maybe didn't tune in, I know that those findings and recommendations for the task force were issued on November the 16th. And I do have a copy of those. The first recommendation that was achieved by that task force was to do this very thing, was direct the Cabinet for Health and Family Services. If you look at the recommendations, the wording, again, in this is almost identical. So this is trying to comply with those recommendations, and I think there was a lot of agreement on trying to create a waiver and to provide some direction for the Cabinet. With that, if you would like to introduce yourselves to the record and then begin any testimony regarding this.
Thank you so much, Chairman Alvarado, and good morning to all the committee. I'm Dr. Sheila Schuster. I'm a licensed psychologist, and I serve as the Executive Director of the Kentucky Mental Health Coalition. Many of you know that I've been in Frankfurt. This is actually my 44th year. I started when I was 10, so I'm still real young. And I think Steve Shannon and I have been trying to get an SMI waiver for probably 20 of those years. So to have the task force appointed, and actually 4 of your committee members served on that task force, and we're so grateful to Senator Kerr for co-chairing that with Representative Bentley. One of the things that we heard over those 5 to 6 months was so much testimony about what we call the revolving door. We have people with a diagnosis of severe mental illness, and then for whatever reason, typically because they fail to continue to take their needed medications, they fall into a downward spiral, and they end up in trouble with the law. They end up under a 202A involuntary commitment. They're in and out of the hospital. They often end up homeless. Unfortunately, some are the victims of violence. Some of them successfully complete suicide. So we have tried for a lot of years to do something about the revolving door. And as Senator Rocky Adams knows, we passed Tim's Law in 2017, and we still are fine-tuning that. You all will see some bills from Representative Fleming to fine-tune Tim's Law. But one of the things that we have come back to over and over and over again is the need for a 24/7 residential supported option for our people with severe mental illness. And let me just remind you that when we talk about severe mental illness, we're talking about those folks that have a hard time separating reality from fantasy. They are people that are prone to delusions and hallucinations, usually diagnosed in early adulthood and then with ongoing diagnoses. So we're talking about people with schizophrenia, people with schizoaffective disorder, bipolar disorder, and so forth. So why have this joint resolution? We asked Senator Alvarado, and we're so grateful for him to have drafted this because we wanted to emphasize the importance of it among the many excellent recommendations that the task force met. We want to point out that adults with severe mental illness are the only adult population with disabilities in Kentucky that do not have their own specialized waiver. And those of you I know are familiar with waivers. They allow you to provide services that would not otherwise be available through traditional Medicaid. So we wanted to emphasize the 24/7 residential option. We wanted to emphasize that they will need supports. It's not just having a roof over their head, although some of them need that as well, but they need the trained staff and the additional services that encourage them, monitor, and help them to stay in the recovery process, which usually involves continuing to take their medication and to participate with their ACT team, the Assertive Community Treatment Team, or other therapy options. This also includes a supported employment option, and we heard some excellent testimony during the task force about how important to people with a severe mental illness diagnosis it is to have meaningful work. And so supported employment would allow them to get ready for work in the marketplace. These are not specialized work programs, but also to have a job coach and to work with employers who would be aware of some of the limitations that people with severe mental illness might have. And finally, we really wanted to make sure that this waiver was about people with severe mental illness only. There are lots of populations in Kentucky, as you know, from the work that was done in the 1915C HCB waivers that include people with developmental intellectual disabilities. We now have a waiver that's in front of CMS for people with substance use disorders. We have acquired brain injury, but we don't want to combine this with any other population. There's a sufficient number of folks with severe mental illness, and they need this waiver to be focused entirely on them. So we're asking for the passage of this resolution to make sure that the cabinet understands the intent of the legislature, that this be an SMI waiver that includes a 24/7 residential option and the supported employment. And I'm going to turn it over to my colleague, Steve Shannon, who you all know, who's great with the numbers, and he can talk about the costs and the cost offsets. And I'm happy to answer any questions. Thank you.
Again, I'm Steve Shannon. I'm with CARP, the Association of Community Mental Health Centers. And really, as Dr. Schuster said, I'm going to talk about the cost. This is not going to be free. It's not a secret. We're looking at the biennium budget. The first year, there's going to be planning by the cabinet, no people served. That's kind of typical. It takes a while to get a waiver approved. Second year, my model, 100 people served. Look at the resolution. It says over 100,000 people who are severely mentally ill. That's not the intent of this resolution, to provide residential services for 100,000 people. You start small, you figure out how to do it. So what I did, this is based on an SCL expansion, Sports Community Living expansion, going back to 2000, I think. There's not going to be 100 people to be served July 1 of the second year of the biennium, which would be fiscal year 24, July 1 of 23. They're going to phase it in, okay? So instead of having 100 people for 12 months, which would be 1,200 months, this would be 8 a month. And probably slower than that to figure out what we're doing, how to do it. So maybe 664 months is the number I come up with. But my estimation, based off the SCL rate, because that's a residential option as well, and again, not all 100 people are going to take a residential option, but many people will because it's necessary. I could come up with a cost of about $4.6 million in the second year of the biennium, and that's under the assumption of phasing it in and everyone taking a residential option. Right now, there's an enhanced match rate, $21.79 on them. That makes it our cost, Kentucky's cost, $960,000. 30/70 is about $1.3 million of Kentucky State General Fund dollars. That's a cost. I'm not going to deny that. This is not going to be free. It's going to make budget neutrality really hard to prove. And I've had this conversation with Senator Meredith many times. Where's the savings? I'm going to be honest about that. There may be cost offsets. There may not be savings. And when I say cost offsets, less ER visits. Not going to spend money there. The ER is not going to get smaller, but they're not going to spend money. There's not going to be people in the ER who don't need to be at the ER. They're going to be supervised. They're going to have case management. They're going to be very, so they're not going to go to the ER unnecessarily. I think it could be 50 visits a year for 100 people. That's not unrealistic for folks who have nowhere to go. They go to the ER. That can save $87,000. Law enforcement involvement, whether it's a 202A involuntary commitment or just a disturbance in the community. As you know, Senator Carroll, it's unlikely one cruiser shows up with a police officer. That happens, 1 or 2 or 3 cruisers may show up. May not ever enter a psychiatric hospital, but it's still using that valuable law enforcement resource to address a problem a residential option can prevent for some people. That's a good use. EMS quite often shows up just because it's a call, 911 call. Those folks won't be going. I think there could be 50 episodes a year with law enforcement. People I've known who are on the streets, who are not in residential options, homeless shelters, who are severely mentally ill, have a lot of regular involvement with law enforcement and EMS, a lot. I had one guy on my porch one day. EMS showed up because we called because he was threatening suicide. And I can remember clear as day, the EMS asked him, "Where do you want to go?" He said, "Oh, it's Thursday. St. Joe's has chicken. I'd like to go to St. Joe's." I mean, he knew the menu. That's not a good use of EMS time. Huge waste of money for EMS time. Residential option prevents that. We have behavioral health crisis response. Another $28,000. $50,000 on police. $50,000 on EMS. Involuntary commitments, 202As. We have staff. All mental health centers have staff 24/7 to do an evaluation. District judge time's occupied. There's discussions in the House on a bill on the involuntary transportation necessary. Sheriff's time. Sheriffs sitting 16 hours with someone before they go to a state psychiatric hospital. Those are all cost offsets that for these folks won't be incurred. The sheriffs will spend their time patrolling neighborhoods, doing their basic law enforcement stuff, not driving 4 hours to Eastern State Hospital round trip. Also, a lot of folks who get admitted to a hospital under involuntary commitment stay longer, stay another 10 days or so. Those are all offsets that we're not going to incur. I can get to $665,000 just with that list. I don't have housing, I'm not homeless shelters, because I couldn't quantify that. But again, Senator Meredith, I'm speaking to you because we had this conversation. These aren't dollars that will be freed up, but they are dollars that can be spent more effectively and used more prudently. That gets us down to $300,000 Kentucky cost with the offsets. Match rate goes back to 30/70, $630,000 what it would cost for 100 people in a residential option, $6,000 a year. Solves a lot of problems. That's my model, and I'll answer any questions about that.
Thank you very much. And you don't even include I've talked about long-term care and nursing homes, and that's inexpensive. You didn't include that in the list.
No, I did
not.
not.
Lot of people there. It would be a much less expensive method of taking care of a lot of those folks. You have a question, Senator Meredith?
Thank you for your presentation. And yes, you and I have had a lot of conversations on this, and you hit on one of the more pertinent points of those discussions. I'm always saying that we don't ever measure the cost of doing nothing, and you've attempted to do that. That's quite obvious. And, I suspect that the savings will be much more dramatic than what you have identified, but you've done a yeoman's job. I appreciate that. But one thing that I would still like to have some kind of measurement for, and believe me, I'm fully supportive of this resolution, is 10 years from now, how do we know we've been successful? And I know that's a difficult question, but it's one that with competing requests for resources, how can we assure the public that we've been successful in what we're trying to achieve here?
I think it's the number of people, and the SMI population is different than other waiver populations. They can be in a residential setting for 2 years and do well, become well stabilized. They could move out into their own apartment. They could get a job 30, 40 hours a week, right? I've known people who have had that support, and we heard it from Judge Burke, was it last week, where she saw a mom in a grocery store whose son went through her court, mental health court, under Tim's law. He's now not in trouble with the law. He's doing well. Those are individual measures that are real stories, right, Senator Adams? Real stuff. That's one way to look at it. The number of people who've gone from homelessness, law enforcement involvement, to their own apartment. I know a guy in the SEL program who's a homeowner. Now, he's got a job.
I also think Senator Meredith.
Those are what I would look at, those changes.
Yeah. I think also, Senator Meredith, that we will see a reduction in the number of involuntary commitments, those 202As. And I think that our agencies that presented during the task force, I'm thinking of Wellspring in Louisville and New Beginnings in Lexington, probably have those numbers, and we can get those numbers from you. I know that state programs, even like Bridgehaven, have tracked law enforcement interactions and 202A hospitalizations, and have demonstrated considerable reductions when you have ongoing therapeutic services. So I do think that there will be information that we can track, actually, in terms of 202A and law enforcement.
And I would recommend tracking that day one of the waiver. Built that
Absolutely.
in.
Yeah.
I would hope we would, because Steve, I have no doubt that your numbers are good numbers, probably a little bit underestimated, but it takes a little bit of a leap of faith to ask for this kind of appropriation when you can't see the direct payback. And I think that's one of the things I'd ask people of this committee and those of us that serve on appropriations and revenue is, let's take this leap of faith. And had a conversation with both Senator Carroll and Senator Adams this morning, again, about this subject about we're not measuring the cost of doing nothing. And this truly is a tragic situation. It's a percentage of our population that has been ignored, overlooked for so many years, and it truly is tragic. So I support this resolution, but more than that, I support any appropriation that we can give to make it a reality. But thank you. Thank you, Mr. Chair.
Thank you, Senator. Any other questions? We have a motion. Is there a second? We have a second. Any other discussion? Madam Secretary, please call the roll.
Senator Rocky Adams, Senator Berg,
Aye.
Senator Carroll,
Aye.
Senator Givens, Senator Harper Angel, Senator Howe, Senator Kerr, Senator Meredith, Senator Nemes,
Aye.
Senator Wise,
Aye.
Chairman Alvarado.
Aye. The matter passes 0. Thank you all for your work. I commend the members of the task force for their work because this is a direct product of that labor. It's very rare when we have a committee meeting where every bill that's presented passes unanimously, so very good work today. Any other questions before this committee?
Thank you all very much.
Thank you all very much. We stand adjourned.
Yeah.